in University of Nevada, Las Vegas, and بشتغل neonatologist at the Children's Hospital of Nevada وclinical professor of pediatrics at UNLV. النهارده إن شاء الله نتكلم عن the basic approach to review articles and meta-analysis, and we'll start from the beginning and see how things go. دي من الlectures بتاعت مجموعة ABCDE. احنا انشأنا المجموعة ديت بعد 25 يناير وإن شاء الله تستمر، لنقدر كنا بنعمل حاجات كتيرة in person resuscitation courses و workshops. في العادة الكورسز والworkshops اللي فيها direct interaction are more useful than lecture، بس هو this topic is good as lecture، فيعني we can proceed. ده هرم موجود في كل حتة مش في مصر بس، ده اسمه evidence pyramid. The evidence pyramid, it rates the value of the literature. فالليتريتشر يعني الحاجات اللي published, the articles اللي published بيبقى فيه ideas, editorials, opinions. My opinion is okay, but it can not be applied to everybody, and other people may have different opinions. في case reports, which is limited experience, but it has its function. Case series, when we have few cases related to the same issue. وبعدين case control studies, which is retrospective, observational study. Cohort studies, which could be prospective or retrospective cohort. برضو بتبقى observational studies. في randomized controlled trials, which is prospective studies. And this is usually the one that gives us the best answer. And when we combine randomized control studies, we come up with systematic reviews and meta-analysis. Systematic reviews and meta-analysis are very important to advance the knowledge, to advance medicine, to advance practice, because it gives the best evidence. To do something, to treat a special way, to investigate in a special way. Long time ago كان في حاجة اسمها narrative review or reviews, just reviews. فالreviews كنا بنعمل one expert in the field. يعني مثلا أنا أشتغل neonatologist, someone asked me, can you tell us, review the surfactant in the treatment of RDS? I decide which article I would write, which issues I will focus on, and write a review. فالreview, I can formulate the question the way I wanted. I can pick whatever studies I like. I don't have to give a specific selection criteria for the studies. And usually I would do a narrative. So I tell you the story. So this is nice. However, because it's so variable from one person to another, we developed systematic review. So systematic review, now we approach it differently. So in a systematic way. So there is fixed issues that we need to address. So first, the review question, we have to be specific, and then we have to write a protocol of how we're going to answer this review question. We select the studies that we will include in this reviews. So it's not a person who selects it. No, we put criteria, inclusion criteria, exclusion criteria. And after we collect these studies that we have met our inclusion criteria, then we review them and we do something called critical appraisal or quality assessment, whereby we can tell, are these studies well done and the results are reliable? So we look at validity. So when we talk about validity, it's about the methods of how the study was done. And Then we add the studies together. We can add them in a narrative, like in a table or graph, or we can do a meta-analysis, and we'll talk about that in a little bit. So systematic reviews are a type of studies that we will focus on. The advantage of this type of study is if you're a physician and you want to study which treatment is better for fever, for example, paracetamol or ibuprofen. So you have to enroll patients in your study, patients with fever. So the patients are called the subjects. In a systematic review, it's a study, but the subjects of your systematic review are studies, are already studies somebody else did, and you look at them, choose them, assess them, and put the data together. So it's a lot of work. However, it's a work you can do on your computer. So you do not need as much resources. You do not need to run specific tests. The statistical software is available. So you can do it as a student. However, it's better if you do it as a practicing physician, and we'll see why. Obviously, being a practicing physicians, whether you're intern, resident, postgrad, this will give you a good opportunity for research that you can do with a computer at home, but it's still a lot of work. So this is the difference between the classical reviews that we used to have and a systematic review that we now generally work with. There are okay, let me see. So there are different types of systematic review. So we talked about it, how we do a systematic review. When we gather the data together and come up with a single number from different studies, that becomes a meta-analysis. And there are something called integrative review, where we do the experimental and non-experimental qualitative review, but this is not our topic. So a systematic review, again, it collates, put together all empirical evidence that fits pre-specified eligibility criteria in order to answer a specific research question. And it clearly stated objective with predefined criteria. It's explicit. So if I put my criteria and come up with specific results, you can also do the same. Anybody can do the same using the same criteria that I used. So it's a systematic search that attempts to identify all studies, and we assess them and we appraise them and synthesize results from them. A meta-analysis is the use of statistical methods to summarize the results of independent studies. So it has the big value of having a larger sample size because you add all the patients in the studies, and we'll see how we can do that, the limitations and the methods of ensuring that we do it appropriately. So we summarize the study. Now we have a much bigger sample size, so our results are much more valid and much more precise. So why do we need to do reviews? One good reason is there are a lot of studies everywhere, and nobody can read all of them and be fluent on what every one of them does. So if we compress them into one study, that would be helpful for the doctors. So they are available in print and mostly now electronic. They can be in different language, which you may not be able to understand. Japanese, German, come from different countries. And sometimes one study will say, oh, this is treatment is better than this one. The other study, no, it says it's not better. So if you do a systematic review, you can figure out which one is which, and are the studies done equally good, and why are there a difference in their results. So you can do it as a student dissertation, postgraduate thesis. So this is something, usually you need more than one person to do a systematic review. So 2-3 people can get together and do systematic review or meta-analysis, and that can be their graduation or promotional project. You need grant funding. You prepare for future research and establish clinical guidelines for your place, come up with an answer and allow information to be assimilated quickly rather than hard work for everybody, and reduce delay of research to clinical practice. We'll probably not talk about it much, but this is a history of meta-analysis, and we'll mention it briefly later on. And this is important research. It is original research. It's just you work with articles, with publications instead of patients. There are issues with systematic reviews that we need to be aware of. They vary in quality. They require updating because if new publication happened, then we have to add that. They may not include all studies. There's, for example, non-English studies are usually not easy to include. There's something called gray literature, which is government advice, people who put their work in books or in dissertation, master degree, PhD, but not published in an article. So you need to look into that because they can be significant source. And how you assess quality can be a little different from one person to another, but we'll see if we can improve that. So you need it to answer a question and get several primary studies and uncertainty. So like we've mentioned before, they're important and they're needed to answer these issues. If you don't know if studies are contradicting, and it's important in research in general and in systematic reviews as part of research, is we just don't repeat what has been done before. We ask a question because the answer to this question is not known. So we want to find a gap in knowledge. We want to find information that does not exist, and we put it together. So we don't repeat things because it's easy to do. We do generate new information. Generally, we use randomized control studies. However, observational studies, like we said, cohort, case control studies can be also included in systematic reviews, particularly if they are related to things you can only do through observation. For example, relationship of birth weight and IQ, white matter, hyperintensities, and morbidity and mortality. Some studies you cannot do randomized control trial because it's unethical, okay? So the randomized control trial, while they're gold standard and minimize bias because you need a good system for randomization, but once it's done, you have it there. However, sometimes it is for randomized control trial may not be ethical. So for example, you want to know the effect of smoking on heart disease. So a randomized control trial would be that you get a group of people, give half of them cigarettes to smoke and half of them don't smoke. Obviously, you cannot do that because we know enough that cigarettes are bad for you, so we cannot do that. So the only way we can have answers to the question is by observational studies. Just follow people who smoke and who don't smoke and see what happened to them. So important for us to understand that observational studies can be included. Not all database for meta-analysis do that. We have to make sure when we analyze the study to check for bias and confounding factors. Sometimes it's difficult to combine different studies, and we will see how we can tell which studies to combine and which not to. Just of mention, you all should know about the Cochrane collaboration, started with a doctor named Archie Cochrane. He's in the 70s, which was 40-some years ago, says it's a great criticism of our profession that we have not organized a critical summary by specialty or subspecialty, adapted periodically, so updated continuously, of all relevant randomized controlled trials. So he says, as doctors, we should have a system by which we update our knowledge and summarize it to be available to all doctors. So he did that. He established the Cochrane collaboration, which is the United Kingdom, and it has lots of reviews. You can register. So if you have a title for a meta-analysis, Cochrane only do randomized controlled trial. You cannot do observational trials with them, but you registered with them a title that nobody did before. So you can go into their database. You have a question about which treatment is better, which test is better, and you look up and see nobody had answered that, or which treatment is better for this specific outcome. If it's not answered, then there is a gap in knowledge. So you go to Cochrane collaboration, register it. Now they will help you. So Cochrane, once you do the search, they can search for you in different languages. So usually you can search in English. Some people can search French or German. They can search for you another language, and they can translate for you and give you the translated articles. They can also help you with the statistics. So if you find a good experiment that has not been done before, a question that has not been answered before, and you go to Cochrane, they can give you good resources to help you with that. So there are stages to how you can do a review. First is problem formulation. So we will go over how do you ask a question. So there is a standardized way. So in medicine, as in everything, we're trying to stay away from individuality to a proven standardized way. It's not that individuality is bad. It's actually, we see like you have 5 professors who in your medical school. So you say, okay, this professor really teaches well. This professor really does good surgery. This professor really does good exam. So we can identify what is good about this professor teaching, what is good about this professor surgery, what's good about this professor exam, and standardize these and use them for everybody. So it doesn't stay individualized and everyone can benefit from it. So we'll first see how we formulate a question, do the search, evaluate and appraise the studies, take the information out, extract the information, analyze the information, and write up that article. So you prepare a topic, search for select studies. So each one has few steps underneath it. You extract, analyze, and report systematic review. So the first one is to prepare a topic with clear answers. So This we teach to all residents and medical students. It's called PICO format, okay? So do you guys know what PICO stands for? Really important. When you ask clinical question, it's PICO. Anybody did any studies? You can write in the chat if you have research question, you want to look up for an article. Okay, a good source for research is Medline. And Medline, when you search Medline, they will actually give you PICO format. So you write Medline and PICO search, and then you put that. P stands for population, problem, participant, patients. I, intervention, indicator. C, comparison, control. O is outcome. Some people add S, PICOS, so you can actually look for S for studies. So if you want a systematic review or meta-analysis, so you don't have to go through many studies. And some people write it PICOTS with a T as for timing, like I just want to know what happened in the last 5 years since this medicine came out, or since we have surfactant. So I don't want to look back 20 years ago because care was different then. Okay, so sometimes they write PICOT, T for timing, and S for the system that was available at the time. But PICO is a generally good approach to do search for anything. So if you're doing rounds and you have an answer, you have a question, you can just go midline, PICO search, enter. So we'll give some examples as we go along. So PICOTS, we've mentioned, population, intervention, comparison, outcome. So the whole idea is just to make sure that we have a standardized way. So once you have a good key question is you guide the entire systematic review, your literature search, then you write inclusion and exclusion criteria for the studies. So you want the randomized controlled trial or cohort, but you don't want case control. Then you want to know the types of data. We'll mention briefly about data that can be binary, like live, die, man, woman, versus continuous, like weight. So weight, the difference between 70 and 71 is the same as difference between 92 and 93. Age, length, blood pressure. So these are continuous data, and then you synthesize the data and report it. Okay, I don't know if you can see this well. Okay. So if we want to fill gaps in knowledge, so L-cycrin is a medicine for blood pressure. So asking, does it reduce blood pressure? That's not a great question. Okay, so because it's already approved for treatment, so we know it does. However, a question that will ask, in specific patients, does it work better than the medication we use now? So that can be a good question. So compare that medicine to medications such as thiazides, for example. Or is the this is now more and more, this is what we're interested in. Is the hypertensive impacted by ethnicity or genomic parameters? That's more so in the United States because we do have different ethnicities and races. However, we look at outcomes. So not just that it decreased blood pressure, but did it decrease mortality? Did it decrease myocardial infarction? Did it decrease stroke? So these are important outcomes for the patients because generally the patient does not care so much that the blood pressure from 140 became 130. They care more that they will not have myocardial infarction. They will not have a stroke. So the clinical outcome that's important to the patient is more so of a good outcome to look for, so you can see, and if it decreases side effects, that would also be an important issue. So we formulated a question, then we have a question in mind. Now, how we'll do that? So we'll develop the protocol now. So now that we have a question, we will decide what studies will be included, what studies will be excluded, how each stage will be conducted, how we'll do the search strategy. Do we have a library with good internet access that they can help us with that? Which studies we'll choose? We can divide the work. So if you have 3-4 people working as a team, you'll do this part, I'll do this part. When we do critical appraisal, but generally what we do is after everybody has done their part, we come together, review it again, and see if there's any discrepancies, and we come to an agreement. The critical appraisal is usually done by a couple or 2 or 3 people individually. So we'll see, I will assess the studies and say, give it ratings, and my colleagues, each one of them will do and see if our ratings match. If our ratings are same, then that's great. If our ratings are different, then we sit together and figure out why are they different. Then we'll do synthesis. Sometimes you need to consult a statistician. Sometimes there is, like Cochrane would help you with the statistics. And then you have to decide how you're picking up, like we said, primary and secondary outcomes. So in studies, there's always primary outcome and secondary outcome. So primary outcome has to be the most important one, like live or die. Okay, secondary out or myocardial infarction, no myocardial infarction. Secondary outcomes will be things like decreasing blood pressure, side effects. So we'll collect the data. So we'll have to have a sheet specifically clear how we're going to collect this data, because some studies report their results as percentage, as a relative risk. We'll mention it soon. Some studies give you the number of patients. So the number of patients is easier if we want to put all patients together. If they don't report that, we can still extract it from the article itself by doing the statistical analysis. So we extract the data, and we make sure sometimes the data also compare the medicine group to the control group, the old medication group. Sometimes they would do it the other way around, like the old medication compared to the new medication. So when we put data together, we align them. So we fix that part here versus there. Make sure that the data extraction is accurate. And if there's disagreement, then we sit together and figure out how we can solve that. So the graph is here. So it's good to have a graph like this. Did we finish this? Did we finish this? Did we search for studies? Did we extract information? Now, when we do search, so we do search at least 2 to 3 database. There's Midline, Embase, Cochrane. Hand search is not that important. However, it's good if you know some people in the field to call them. So this is an important part, is you don't want a very wide question that you have loads of articles to review and they don't give you the point that you're looking for, but you also don't want to be too narrow, because then you will not be able to get enough to answer your questions. So the balancing between precision, which is specificity, and your sensitivity to get everything that you need to be okay. So you want, when you do systematic reviews, you don't want to end up with 1 or 2 articles, but you don't want 3,000. So in teens are reasonable. So when to determine study eligibility criteria? Should that be determined after the abstract review process is underway or before that? So if I'm doing eligibility criteria, I would put it before the abstract review process, because when I review them, I need to see, I'm not going to read every article, I'm going to read the abstract. The abstract is the summary of the article that's on top of all articles published. So I read it, and then I can tell what type of studies. Does it include the patients that I'm interested in? Does it include the outcomes that I'm interested in? So I need to determine the study eligibility criteria before I look for studies. So a well-constructed study eligibility criteria will help avoid all these. Too much literature to review, inability to answer the question, or bias introduced through inclusion of inappropriate study design. So we need to do that before we start looking for studies. Okay, so critical appraisal, which is quality assessment, is we have to look. Now we have a question, clear-cut, PICO format. We searched for studies, and we had eligibility criteria for the studies, just like we have eligibility criteria for patients. If we're doing studies on patients, we pick the articles that we're going to review. Now we have to assess these articles. We have to do quality assessment. Are these articles valid? Valid means well done. And are they relevant to our questions? So we have internal validity, applicability, and precision. We'll mention briefly what's confidence interval, which tells us about the precision. So studies generally have magnitude and precision, and there is good ways to help us assess. You don't need to read this, just know there is something called GRADE, Grading of Recommendation, Assessment, Development of and Evaluation. This is after you've gathered your systematic way to approach recommendation. So we'll do this later on. And meta-analysis, it is a set of statistical technique for combining information. So we're collecting the data from the studies. We may be able to combine them, we may not. If we're not able to combine them, then this is just a systematic review. If we can combine the results together, then that would be a meta-analysis. So a meta-analysis has a statistical outcome to this. So it's obviously good if we can combine them together. So it's a quantitative, so we use numbers. Systematic, so we use methodology. We combine them together, and we provide new knowledge. In the statistical analysis, we need to know a few terms. We need to understand rate difference. So we call it, there's experimental event rate, control event rate, like how frequent the outcome is happening in the two groups, control groups versus the study groups. So for giving medication, new medicine versus old medicine for blood pressure. So the new medicine will be the experimental group. So experimental event rate, lived or died, versus control event rate, the ones using the old medicine, lived or died. So that will be either relative risk or risk ratio, it's the same thing, versus odds ratio. Sometimes if we're using continuous variable like blood pressure, so standardized mean difference, we would use that at that time. So what is the mean decrease of blood pressure? between this group and that group. So we can tell which group changed more. So in that case, we use different statistical approach. Case control, we always have to use odds ratio. We'll see when do we do odds versus relative risk. And there are two models. Generally, there is called fixed effect model and random effect model. So in the fixed effect, we assume that there is only one issue that's changing, which is our medication. Random effect, that we assume that there are different issues that could be affecting that. So sometimes what we actually, when we do the statistics, we will run with the statistical package the two models and see if there's actually difference in the outcome. So this is further explaining the fixed effect versus random effect model. So the random effect, because we assume there are more issues that can interfere with the results, there may give us higher heterogeneity. So what is heterogeneity? Now, people do studies. So I can do pediatric study patients from 1 to 5 years old. Someone will do a similar study, but instead of 1 to 5, they will do 3 to 10. So can we combine the two studies? Okay, so we have to look, they're not exactly same patients, and that's most of the time, nobody does that. I can do the studies for follow-up for 6 months. Somebody else does follow-up for 2 years. Can we put these two studies together? Can we combine the number? Or these studies are too different to be able to combine them together. So we can do a systematic review, but not a meta-analysis. So we call this heterogeneity. And heterogeneity, it could be the methods are different. The study design is completely different, so we cannot combine them. They can be clinical heterogeneity, that the participant, the study design is randomized controlled trial in both of them, but the patients here are very different from patients there. Or they could be statistical heterogeneity. So these two parts, whether the methodological heterogeneity or clinical heterogeneity, you can tell the difference by looking at the study itself and going through the protocol for the study. Inclusion criteria, how long is the follow-up, what's the primary and secondary outcome. So we can determine that by looking at the study. Statistical, there are a couple of ways to figure out that. The statistical heterogeneity, there are a few ways to assess that. So there's something called I-squared, Cochrane Q, T-square. So we look at the I-squared, and just for you to know, we don't have to know how it's done. It's usually just some statistical software we can do that with. If the I-squared is low, it's 0 to 40, that there's no heterogeneity. Okay, if there is more, like 75 to 100, these are very different studies. You should not put them together. Okay, there are obviously issues with the statistical analysis. However, Cochrane Q and T2, you have to do them as well. So there is no method that's perfect, but we run 2 or 3 of them, so we're sure of our outcomes. So we've mentioned that there's binary outcomes, yes, no, versus continuous outcomes. So for binary outcomes, we do the statistical analysis We look for relative risk or odds ratio. So we look for, usually we put in the horizontal the intervention, and in the vertical the outcome. So these are two studies. So study X, study Y. So we have treatment group and control group. So in the treatment group, the outcome was 5 and out of 25. So for example, we're looking at 5-year survival. So 5 people survived out of 25. In the control group, 6 people survived out of 25. Are they different from each other? So we look at when we do that, we get them into when we combine these two studies, they have different number of patients. We use the raw numbers, like the number of patients here, number of patients there. We add them together and come up with a result. There are guidelines for how we can do that. So this is called PRISMA, or Preferred Reporting Items for Systematic Reviews and Meta-Analysis. So they will tell you how to do that. And so you need obviously to read that before you start, so you can take that into consideration. And there is, if they report odds ratio and risk difference, we convert that to numbers. And we'll do that. So hopefully, we'll go very briefly, relative risk versus odds ratio. So relative risk is very easy for doctors to understand. It's called relative risk or risk ratio. So for example, if I have a risk of getting COVID of 50%, and so my colleague has the same risk, 50% of getting COVID. I go get the vaccine, and my risk for getting COVID is now 25%. So my risk relative to my colleague's risk initially, like before getting the vaccine, was 0.5, 50%. We converted to decimal, so it becomes 0.5. And my colleague's risk is 0.5. So 0.5 over 0.5, that would be 1. So relative risk of 1 means we're similar, we're the same. Now, when my risk becomes 25%, that is 0.25. So 0.25 divided by 0.5 of my colleague. So now that becomes relative risk of 0.5 or 50%. So I've cut my risk for getting COVID by 50% by getting the vaccine. So that's generally an easy way, and doctors understand that well. Odds ratio or a calculation is a little bit different, so it takes a little more calculation, but we understand them both about the same way. When your relative risk or odds ratio is 1, it means your risk is the same. If it's less than 1, your risk is less for developing that outcome. If it's more than 1, then your chances are more likely to develop that outcome. So, like we said, it's easily interpreted. We try to do relative risk. The relative risk is used in prospective studies. If you do retrospective odds ratio, you can use in all types of study, retrospective or prospective. But relative risk is only in prospective studies because you need the denominator. This is actually a quick the relative risk. So we always put them into 2x2 table: treatment, control, outcome, events or no events. And so my risk A over total, control C over total, and then you divide what comes from this by what comes from this, and it gives you the risk ratio or relative risk. The number needed to treat is very important for a clinician because I want to know how many I need to treat to get good results. or to get the outcome that is desired. So the number needed to treat, you get it from risk ratio or relative risk easily. In the example we've mentioned, my risk is 25%, which is 0.25. My colleague risk is 50%, which is 0.5. So the risk difference, or sometimes we call it absolute risk reduction, ARR, 0.25 minus 0.5 is 0.25. So 1 over the risk difference, which is 0.25, gives us 4. So 4 is the number needed to treat. So it means I need to give the treatment to 4 people, so number 5 does not get the disease. So if we assume that these data is accurate, getting the vaccine to 4 people will save number 5. So this is called the number needed to treat. Now, the number needed to treat is important because it depends on how easy the treatment is, how much does it cost, is it problems? So in continuous outcomes, we'll usually look for difference of comparison groups, so mean and difference in mean and standard error of the mean. It's a little more complicated for statistics. We look at p-values. So, but the statistics part is a different part of the evidence-based medicine or statistical analysis. So that's what we look. We do the statistics, combine them, and see. So generally, this is what we look for. This is called the forest plot. So each one of these lines is a study. So I found 5 studies about umbilical artery catheterization in newborns. So where do I put the catheter, high or low? So I found 5 studies that compared both of them. So each of this study, the middle point is called the point estimate, or the relative risk for the outcome, which is death. And the line from here to here is called the confidence interval. How confident I am that this is the outcome. So we usually like to be 95% confident. In medicine, as in life, you cannot be 100% confident. So 95% is good enough. So if you look at these 5 studies, do they look similar? Do they look that we can combine them together? Yes, no, maybe? So if we look, they're pretty close. Their confidence interval, they overlap. Like you can see these big lines, they all overlap. So by eyeballing them like this, I'd say, yes, these are not heterogeneous. These are statistically homogeneous, and we can combine them together. Okay, this is called forest plot again, and this has to do with patellar resurfacing, yes or no, to decrease pain. So again, we have 5 studies, and this is the summary. The diamond is the summary. So we look and we see this study is all the way here. This study is here. This study, the confidence interval, does not touch this side at all. So these studies look different from each other. Okay, so this one and this one, they're different. They don't overlap at all. So just by looking at them, we'd say, no, you should not combine them together. So this is one way we can tell. If we combine them together, then there is other, as we've mentioned, the I-squared, which this is the statistics for it. It's not too complicated. We'll try to wrap it up because we're running out of time. We've mentioned that. So there is a Prisma. They give you a checklist and how to do it. So it's a very good way to start. You get this checklist and you say, okay, this is how we're going to choose my title. This is how we're going to write the abstract. This is how we're going to write the introduction, methods. Make sure I include information about each of these points. This is how I'm going to write the results. And there is study characteristics. There have to be some flow sheets to explain how we approach the process. This is how we write the discussion. This is how we do mention if we got money to do the study or not. So it's fairly well-detailed process, and it's helpful to do that. Then after you do everything, you do what's called the executive summary, where you structure it, summarize everything, the background, objective, key question, method, results, conclusion, and implications. So it is something doable. You can do it as a junior physician. You obviously need to know, to have some skills in critical appraisal and statistics, but the information to do a systematic review or a meta-analysis is available online, and it can be done on your computer. And that's the advantage of this process. You need some skills on how to appraise an article and how to choose it, and you need preparation. So Prisma, the checklist that we put in, would be helpful for that. Thank you for attending. I know this is not an easy topic, but let's see if you have any questions in the few minutes that we have.
Thank you, Dr. Alaa. Hey guys,
if you have any questions, you can write them in the chat. Can we search about the question itself? Okay, so that's why we were saying generally to do a meta-analysis or systematic review, you would be a physician taking care of patients, because usually the question starts with the patient. That's why in the PICO format, the first P is for patient, problem, population. So you have to know what is important and what's not. And so you have a patient with an issue. Should I use this medicine to decrease his blood pressure, or use that medicine because he has this comorbidities of diabetes, or has this problem with his legs? So you start with a patient or a problem. Then you formulate a question. So the question has to be clinically pertinent. It has to be helpful for your population or helpful for your specific patient. So you do not search the question itself. The question has to come from you. And then once you have a question, you put it in the PICO format and see, maybe somebody already answered. Maybe somebody already did the meta-analysis. If nobody did it, then that would be a place, there is a gap in knowledge. There's knowledge missing. We don't know the answer to this. Let me try and find out. So now you can do your systematic review and find out if there is enough. Or you may find articles about the issue, but they're contradicting. This one says this one says the opposite. So if you bring them together and do your critical appraisal, you can say, yeah, this article is better than this one because this one was poorly done. So we'll go with this one. And there are two articles similar, so we'll put them together and do a systematic review. So you do not go to Google and say, give me a good question about newborn babies with respiratory distress. You have to come up with that yourself. Excuse me. Second question says, so should we search in all databases? So the medical databases, like obviously you can search Google, but you'll get hundreds of thousands of results. But if you search databases, you can search it using PICO. And you should search at least 2 to 3. minimum. If you do want more medical databases, there's Embase, there's Cochrane, Midline. Psychiatry, they have their own databases. So if you're in psychiatry, you want to include psychiatric database. Physical therapy, they have their own database. So you don't need to search in every single database, but you need to search 2 or 3. Okay, any other questions? Okay, last question. It says it's hard to figure out if there is a knowledge gap. Okay, so this comes with your practice. So like you do rounds and the doctor, your senior physician, your professor says, this is how we should give him this medicine to this patient because his condition is this. So that's a question. That's a good question to format. So in my patient with myocardial infarction is medication, this medication is better than stint, for example, because the stint is the other treatment suggested. So in elderly patients, for example, with myocardial infarction is treatment with this medicine better than a stint. So I don't know if there's a knowledge gap or not, but you can format this as a PICO and put it in Midline and see if the answer is clear or not. Maybe somebody did it, maybe somebody did not do it. So then you can find out. So, or if he asks you, should we, this patient has diabetes, what range of blood sugar should we keep the patient at? Or this baby has respiratory distress, what level of oxygen saturation should we maintain? 85 to 90 or 90 to 95%? So these are all questions. Sometimes we know the answer, sometimes we don't. Sometimes we think we do, but we actually don't. So by practicing, by putting few questions, you will find the knowledge gap because there is lots of gaps and things that we don't know. Also, there are the new things that come up. So is the new method better than the old method? Or is it better for everybody? Or is it better for specific patients? So there are definitely new gaps because we come up with new technologies, with new medicine. So only by practicing, you can tell whether there's a gap or not. Okay. Sure. Can I help with some projects? Definitely. So I will write my email and you guys can email me and we'll see if we can help you do a search, help you find a good resource for things. So this is my email. It's an easy one, so you can communicate. Okay, thank you very much. Thank you, Mustafa Razaz and the group at Qasr Al Aini, and inshallah we'll have more cooperation, probably in something in person eventually, inshallah, when COVID is done, probably resuscitation and things that you can use in your practice right away may be helpful.
إن شاء الله. شكرا دكتور علاء.
شكرا. مع السلامة.
مع السلامة.